Red color granules are your malariadent bodies. Alpha-1 antitrypsin. The bodies are actually alpha-1 antitrypsin themselves. They are produced but not being released. ORS only. Okay, so we are seeing gas. Peritoneum is in stage 3, but it's not in the answer. But stage 4, let's go with 4. No, it's 2B. So stage 2 has A, which has air in the intestine, and B, which has air in the portovenous. In stage 2 also has a metabolic triad of acidosis, hypernatremia, and decreased platelets. So this is air in the portal vein. It is to be. Pigmentation has no effect. Again, pneumatosis portalis is to be. 3. Juvenile rectal polyp. First child is not severe. This looks like a jejunal atresia. Gastrographin follow through.
The given clinical scenario in which the child initially had tracheoesophageal fistula, then underwent a surgery, and now is having these respiratory distress, barking cough, is typical of post TEF repair tracheomalacia. The other options are incorrect. Bronchial asthma will have history of allergen exposure, allergy, history of similar disease in family, a history of atopy. Croup, while will have barking cough, but here they have specifically mentioned that the child earlier had tracheoesophageal fistula. Hence, tracheomalacia is a better answer.
Answer is ventilation perfusion mismatch because of increased dead space ventilation. Answer is give IV antibiotics and refer to higher center. Answer is Staph aureus pneumatoceles. High dose dexamethasone. We are thinking about laryngotracheal bronchitis or croup of moderate severity. This is neonatal pulmonary alveolar proteinosis. Child has pneumonia. Criteria for fast breathing 0 to 2 months, more than 60, 2 months to 1 year, more than 50, 1 to 5 years, more than 40. 0 to 2 months, more than 60, 2 months to 1 year, more than 50, more than 1 year, more than 40. What is false? The baby doesn't have pneumonia because they are 6 months old, so they fall between 2 months to 1 year, where the heart rate more than 50 is considered high. The respiratory rate of this baby is normal. So this is correct. Antibiotics not required. Wheezing to be treated. Bronchiolitis is a likely cause. 6 month baby, so comes under 2 months to 1 year, where 50 is the normal respiratory rate. So respiratory rate is normal. Number two is not correct. This is a 2 year old child, so comes and more than 1 year, normal respiratory rate is more than 50. Sorry, more than 40. And here, respiratory rate is 36. So respiratory rate is low. We are suspecting laryngotracheobronchitis. Dexamethasone. In the above chest X-ray, we can see hyperinflated left lung with increased cardiac shadows and bilateral diffuse haziness. Patient of pneumonia on mechanical ventilation. With the above clinical picture, it is indicative of child developing acute respiratory stress syndrome as a result of volume trauma. Hence, decreasing mechanical ventilation setting is a management of choice. Hyperinflation, decreased mechanical ventilation. First, ampicillin is given, followed by ceftriaxone, because here the patient has H. influenzae pneumonia. Some strains of H. influenzae have developed modified penicillin binding proteins. That's why we give ceftriaxone.
The AM/PM variation should be more than equal to 20%. Features of pediatric asthmas are as follows. FEV1 FVC ratio less than 0.8. Bronchodilator response more than 12% or 200 ml. Exercise challenge worsening by 15%. Daily peak flow AM/PM variation should be more than 20%. Here it's written 15%. That's why this is wrong. Carter-Jenner syndrome. 8 months. So 2 months to 1 year. normal respiratory rate is more than 50. Oral antibiotic. Explain danger signs and send home. This is acute lymphoid leukemia.
So the peripheral smear shows lymphoblast. As you can clearly see, they have very high NC ratio. It is the cytoplasm is barely visible. Most of it is just nucleus. The nucleus do not have any nucleoli. Okay, they do not have any nucleoli. They do not have any granularity. They do not have any OR rods. All of this points towards that these cells that you are seeing, the image that you are seeing, these are lymphoblasts. Other findings in the question itself that suggest this is a ALL, that is acute lymphoblastic leukemia, is that it is the history given is that of a child. In children, we know the most common malignancy is ALL. Also, he has widespread lymphadenopathy. Again, lymphadenopathy occurs more in ALL as compared to AML or JMML. It cannot be aplastic anemia because aplastic anemia unlikely has lymphadenopathy. Aplastic anemia won't show these lymphoblasts. It won't be AML because, as I told you, these are lymphoblasts rather than myeloblasts.
So here you are seeing the cells which are entirely blue, no nucleoli, no granularity, very little cytoplasm to no cytoplasm, no OR rods. OR rods are present in myeloid. And then the f- the it is a 6-year-old child. Most common in six young children is acute lymphocytic leukemia, lymphoblastic leukemia, and lymphadenopathy is also common in lymphocytic leukemia compared to myeloid. So here the answer is acute lymphocytic leukemia. Factor VIII deficiency. Factor 13 deficiency. So whenever the question is um, about bleeding from the stump, you should think about factor 13 deficiency and Glanzmann thrombocytopenia. In factor 13 deficiency, fibrinogen stabilizing factor deficiency, PT, APTT platelets will be normal. ALL in children. Point mutations. Sickle cell disease. So in sickle cell, GAG is made GUG. GAG gives you glutamic acid. GUG gives you valine.